صوتي واضح؟
ايوه دكتور هولو, how are you?
Hi, welcome everybody.
Welcome Gabor, how are you?
Thank you. I'm very happy joining you.
It's our pleasure. I think somebody should say something. The participants.
Well, I do hear all of you.
Yeah, we can hear you.
Yeah, thank you.
دكتور نادر انت سامعني؟
دكتور ايمن ايوه انا سامع حضرتك. مساء الخير، ازي حضرتك؟
مساء النور.
دكتور هولو, good evening sir, nice to meet you.
Hello, nice hearing you.
Thank you sir.
Okay, should we start sharp at 8, okay?
It's 7:58, it's about 2 minutes to 8.
Okay, so we're going to start at 8 sharp.
I just lost you. Do you see me?
Yeah,
Yes,
of course.
Yes sir, clearly.
Because for whatever reason I do not see you for whatever reason. Do you see me? Oh yes,
yeah,
maybe this one. Okay, now I'm fine. Now I'm fine with that. Sometimes it's a bit tricky. Okay, now it's fine.
If you press on the gallery view, you'll find more videos.
That's just disappears from the screen. That's
yeah.
That's okay.
مساء الخير، سامعني كده كويس يا ايمن؟
ممتاز يا كريم.
ازاي اخبارك؟ وحشنا خالص. ازيك؟
الله يخليك. Hello, how are you?
Usually we have, the number keeps rising in the first few minutes, so probably, dear Ayman, we start at 8:05, inshallah, 8:05. We start, there's only now 127, 128. So 8:05 we start as we did in the past few times.
Sure.
We are waiting also for Dr. Ali Khalifa. You are muted, Ahmed.
Dr. Ahmed, you are muted.
You are muted, Ahmed.
Sorry. So, no, I was just telling Gabor and telling you we hope to do the first physical meeting for a while by the end of October. So we plan for a small physical meeting, maybe maximum attendees of 150, physical attendees with good social distancing, and then it will be open also virtual for anybody who wishes. So, but we are holding firmly to the possibility of doing it physical this year, because it's almost 6 months with no meetings at all in the region, and actually in so many places in the world, I'm sure.
Thank you.
We hope we are able to do this.
Cross my fingers for you.
Yes, thank you. احنا دلوقتي I think لسه قدامنا a few minutes.
We are waiting for Dr. Ali Khalifa.
He's in already.
Okay. Okay.
Good evening, Dr. Ali.
Welcome back.
Good evening.
Good evening.
Dr. Adel Bey, good evening.
I think we can start now. Dr. Mohammed, Bashmuhandis Ali.
Okay, Dr. Ahmed, we are still building up some numbers. We are now 210. If you can
Yes,
wait, if you can
220.
wait just a few seconds, maybe.
Few seconds, okay.
If you can wait, okay, just a few seconds.
A minute.
To make it, okay, sorry, a few minutes to catch as many numbers as we can.
Okay, let us start, Ahmed, please.
Yeah, let us start. Let us start, Mohammed.
Okay, Doctor, okay, we can start now.
Good evening. So we are happy today or this evening to start our third episode on the Glaucomatology CME program. We received rave reviews about our first two episodes, and we hope that we are keeping on this sequence of glaucoma education for the general and specialist, for the general ophthalmologist and the specialist. Today is the last episode in the examination and evaluation of the glaucoma patient, and our episode today is on optic nerve, and we have really four renowned international names. We start with our dear friend Professor Gabor Hollo from Hungary, from Budapest in Hungary, and then we go with Professor Dr. Ali Khalifa with his talk on the clinical evaluation of the optic nerve head, to be followed by Professor Ayman Shayati with his talk on the disc damage likelihood scale, which is an interesting perspective into the evaluation of the optic disc. And last but not least, the OCT in glaucoma. Not only the OCT, Professor Dr. Karim Rafat is going to talk us through the important topic when we should go for structural test and when we go for functional test. So we are looking, and this is, I know from Professor Karim that this is like a brand new talk he has been working on in the past few weeks. So we are all looking forward to hearing all these talks.
Do we have commercials from Arcadia, or do we proceed with our eminence next speaker?
We have a 50-second commercial by now.
Hello, doctor. Greetings from Arcadia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about glaucoma patients. Twinzol brings patients to the targeted IOP regardless of their baseline. Twinzol reduces the IOP by 30% for patients whom IOP is more than 25 mm mercury. And for those whom IOP is more than 30 mm mercury, Twinzol could reduce it up to 50% of the IOP. Another product for your glaucoma patients is Alpha Nova. Alpha Nova is the perfect add-on therapy with a superior neuroprotective effect, along with less incidence of ocular allergy, as Alpha Nova is preserved with sodium purite. Finally, I would like to remind you with OcuGuard, a tailored formula of vitamins, minerals, and herbs. Thank you for your time.
Okay. Now The glaucomatology webinars are honored to introduce our very eminent professor, Professor Ali Khalifa, who is going to present to us the clinical examination and evaluation of the optic nerve head in case of glaucoma. So, Professor Khalifa, please take the lead. Thank you very much, sir.
Share the screen. Good evening, dear colleagues. Welcome to this online course. Please keep distance in space, but not in heart during this epidemic. My talk today is about clinical evaluation of optic disc in glaucoma. As you all know, glaucoma diagnosis in clinical practice depends on the intraocular pressure, optic nerve head assessment, standard visual fields, retinal nerve fiber layer, and OCT and ganglion cell count. But there are limitations of the intraocular pressure. As we all know, corneal thickness affects accuracy. Thin cornea underestimates intraocular pressure, while thick corneas overestimate intraocular pressure. Also, intraocular pressure fluctuates. Our morning intraocular pressure are higher than the evening intraocular pressures. Also, the intraocular damage threshold varies. As we know, ocular hypertension, we have a high pressure but no field changes, while in normotensional glaucoma, we have low pressure with visual field changes. Therefore, there are limitations of visual fields. They are subjective, they are very highly variable, and they have a poor sensitivity. Visual field abnormality are not replicated 86% of time. First, we have an abnormal field, then the second field followed is normal, then the third field is outside normal limits. And visual fields have a poor sensitivity too. 50% of the optic nerve fibers are lost prior to visual field defects, and by the time there is a 5 decibel loss, there is a corresponding 25% loss of retinal ganglion cell. Therefore, a large number of retinal ganglion cells are lost prior to detectable field abnormalities. Therefore, early glaucoma can be missed if a clinician relies mainly on the visual field and intraocular pressure. Today, glaucoma is an optic neuropathy. Therefore, it is logic that you diagnose glaucoma from the optic nerve head. The assessment of the optic nerve head and retinal nerve fiber layers are needed for early glaucoma diagnosis. And by a simple direct ophthalmoscope or biomicroscopy or a fundus picture of the optic nerve, you can detect glaucoma. As we all know, structural changes occurs before functional changes. Retinal fiber layers loss occurs first, then the optic disc changes occur, and lastly, the short automated perimeter. As we all know, retinal nerve fiber layers start 6 years before any visual field changes, and 25% of the optic nerve are lost before any kind of visual field changes. And when short automated perimetry changes occur, you have a red flag. That means it is quite affecting the optic nerve. Therefore, there are 5 rules for the assessment of the optic nerve head in glaucoma, as Remo Susana put it. This course was developed by Remo Susana in Brazil, Philip Medriois, and Robert Weinreb. This is Professor Susana with me in Brazil. The 5 rules: first, look at the rim and not at the cup. Second one, look at the peripapillary region. Third is look at the retinal nerve fiber layers. Fourth, look at the lamina cribrosa. Fifth, look at the optic disc image. These are the 5 rules, and we're going to take them in one after each other. Rule 1, identify the rim. Look at the scleral ring and the cup border. This is the scleral ring, the whitish ring around the optic disc between it and the retina. And this is the cup border. Where is the cup border? It is the first bend of the blood vessels inside the optic nerve. This is very important to locate. The first bend inside the optic nerve head. Therefore, the rim width is the distance between the scleral ring and the location where the vessel is bent. That is the cup border. This is the width of the rim width in the optic disc. They differ in size. Here, that's the scleral ring. That is the kinking of the blood vessel. That is the cup border. And that's the rim width inside the optic nerve head. It has to follow what is called the isn't rule. Inferior, superior, nasal, and temporal rule. The biggest is the inferior, then the superior, then the nasal, then the temporal. Anything else than that, you should suspect glaucoma. Then comes the color of the rim. If you look at this optic disc, that is the kinking of the blood vessels. That is the cup. And here we find that the cup equals to the inside pallor. And when the cup is equal to the pallor, that is a normal disc. But if the pallor is more than the cup, that's a neurological disorder or a glaucoma with a very high intraocular pressure. And if the cup is greater than the pallor, this case is a glaucoma. So here the cup is equal to the pallor, the white, therefore this is a normal disc. If you come and look at this picture, we'll find that here is the kinking of the blood vessel and denotes the cup. And we find that the pallor is greater than the cup, therefore the pallor is greater than the cup, therefore this is a neurological, not a glaucomatous cupping. Non-glaucomatous optic neuropathy. If you look here also, look at the cup where the blood vessels are first bent, then we look at the pallor, we find that the pallor is more than the cup, and this is also a non-glaucomatous optic neuropathy. If you look at this back picture, take care of that one, we find that this is the pallor. But where is the first kinking of the blood vessel? If we look carefully, we find that's the location of the kinking of the blood vessel, and this is the cup. Therefore, in this one, the cup is bigger than the white pallor. Therefore, this is a glaucomatous case. This is an excellent example of a glaucoma case where the cup is greater than the pallor. We don't diagnose glaucoma by the pallor or the size of the pallor. It is by the size of the cup. Here, look at that. That is the location up there, and this is the cup. Therefore, the cup is greater than the white pallor. Therefore, this is a glaucoma case. Here, there is something called nasal cupping. If we look, it is painted in blue. That is the cupping. That's where the blood vessel is first kinked. And the white on the nasal side is smaller. Therefore, the cup is greater than the pallor nasally. Therefore, this is a case of glaucoma. Also, there is a hemorrhage on the edge of the optic disc. Rule 2, we look at the peripapillary region. As we all know, we have the alpha zone, which is next to the optic disc. When beta zone occurs and or intervenes, it pushes the alpha zone outside. The alpha zone is pigmentary area, while the beta zone is atrophic areas, whitish area next to it. That is the beta zone. And beta zone has a sensitivity of 20% to 30% and specificity 80% in glaucoma. Here, if you look at this side, that's the alpha zone, hyperpigmentation of the pigment epithelium, while the beta zone is atrophy of the pigment epithelium, and you can even see blood vessels of the sclera behind it. Rule 3, we have to look at the retinal nerve fiber layer. Normally, the retinal nerve fiber layers are blackish and whitish striations going into the optic nerve head. And when you look at it, you find them as bright striations in the background, especially with the red-free photographs. With the red-free, or the slit lamp, with the red-free, you look at it, you find them as bright striations. That is normal. Here, when you lose the nerve fiber layer, you find a black striations like the arrows here showing. Here's the black striations, and on the right side also the black striation, sector shape, while the white area is normal. This is schematic drawing. First, there are slit-like loss of retinal nerve fiber. Then they start enlarging until they become totally loss of nerve fiber layer. Here we have a localized retinal nerve fiber loss, and it's called Hoyt who first described it. And with this loss of nerve fiber layers, you usually see a notch corresponding to it. And this is very diagnostic of glaucoma. And of course, as we all said before, better seen with a red-free light. Here there's also localized retinal nerve fiber loss, wedge-shaped dark area between the two black arrows is seen, and this is indicative of glaucoma also. Here there is also a wedge-shaped black area indicative of glaucoma and loss of nerve fiber layer. Here we have to carefully look at this picture. If you carefully look, you might see slit-like losses of retinal nerve fiber layers in the upper temporal area. These are loss of retinal nerve fiber layer, and you may lose or you don't see them if you are taking a quick look. These bright striations show normal nerve fiber layers on the left, and when you lose these bright striations, the blood vessels become more prominent and more visible. On the left side, we have a normal retinal nerve fiber layer, while on the right side, we have diffuse retinal nerve fiber layer loss. Rule 4 is we look at the lamina cribrosa. Normally, the holes in the lamina cribrosa are round, and when they become more lengthened, they become striated. This is Susanna sign, and it is a sign of glaucoma. Also, if we look and we find an acquired optic pit, which is called radius sign, is also a highly significant sign of glaucoma. Remember that a normal large disc has a large cup. This is we have a large cup here. This is a large disc and a large cup, but this is normal because it is the cup equals to the pallor. And also isn't rule is opaque. The inferior is the biggest, then the superior, then nasal, then the temporal. Be cautious with myopic discs, because in myopic disc we have the atrophy around it. It is very difficult to diagnose the cupping and the edge of the disc, but here this is the scleral ring. If we carefully look at the optic disc itself, where is the first bending of the blood vessel? Here is the first bending of the blood vessels, and this shows that we have a very thin rim. And taban, it is very diagnostic of glaucoma in case of high myopia and atrophic peripapillary area. Rule 5 is we look for the optic disc hemorrhage. These optic disc hemorrhages are flame-shaped. They normally disappear after 2 to 6 months, and they are indicative of glaucoma progression. You have to look carefully because you may not see them, and you may recognize them as a blood vessel. So you have to have a good look at them, either by a picture or if you're looking through a slit lamp, you have to carefully look out for them. Here also, see they look as if it is a blood vessel. On the right, the minute hemorrhages on the blood vessels on the disc. Here also, that's another picture of different types of hemorrhages along the blood vessel. These are the 5 rules of how to diagnose glaucoma from the optic disc. And thank you for your attention.
Thank you, Dr. Ali.
Thank you.
Thank you very much, Dr. Ali Khalifa, for this excellent presentation about the evaluation, the clinical evaluation of the optic disc in case of glaucoma. Thank you very, very much.
Thank you.
And I would like to highlight to our audience the points that Professor Khalifa highlighted, which are the take care of the pallor, take care of the judgment of the optic cup. It's the kinking of the blood vessels, as Professor Khalifa mentioned, rather than the pallor. This is a very common mistake. We just highlight this. Please, for all our attendees, take care of that. Carrying on with this excellent presentation about the clinical examination of the optic nerve, we would like to invite our next eminent speaker, Professor Ayman Al-Shati, to talk to us about the issue of the disc damage likelihood scale, which is a very sensitive issue in the examination of glaucoma as well. So, Professor Ayman Al-Shati, please take the lead.
Is my screen clear now?
Yes.
Okay, so my talk is a continuation of what Dr. Ali has begun. It's about disc damage likelihood scale. We agree that glaucoma is a progressive optic neuropathy with characteristic structural and functional damage. And by structure, we mean the changes that occur in the ganglion cells and the retinal nerve fibers, and these can be assessed by examination of the optic disc. And by functional, this can be assessed by visual field testing. And we have long been depending on the cup disc ratio for assessment of the optic disc, as Dr. Ali has just mentioned. That's we compare between the diameter of the cup to the whole diameter of the disc. And sometimes we refer to the vertical cup disc ratio as a more precise measure of the cup disc ratio. However, look at these 3 discs with 3 different cup disc ratios. Maybe the first one may be 0.7, and the second one may be 0.5, and the third one may be 0.3. And you may think that these may have different risks of glaucoma, but actually the one on the left-hand side is a big disc, and so, or large disc. And as Dr. Ali has mentioned, usually the large disc has large cup. So although the cup disc ratio is different between these 3 discs, but the risk of glaucoma is almost the same. So the cup disc ratio does not consider the size of the disc. And look at these 2 discs together. These are discs of the same size and of the same cup disc ratio. But if you look here, you'll find the rim is very thin, and here the rim is not that thin. So these 2 discs do not have the same likelihood of having glaucoma. So the cup disc ratio does not consider the rim, although, as Dr. Ali had just said, that the rim is the most important part of the examination. So Spaeth put forward what he called disc damage likelihood scale. And here he doesn't compare between the cup diameter and the disc diameter, but between the rim diameter and the disc diameter. And he looks at the thinnest part of the rim. So in this part, you'll find that the rim is very thick, and this is midway, and this is a thin rim. And he considers that if the rim disc ratio more than 0.4 like this, 0.3, 0.2, 0.1, or less than 0.1, And if the rim is lost, then he describes the extension of the loss of the rim, whether it is less than 90 degrees, 90 to 180 degrees, 180 to 270, or more than 270. And then he put down a scale from 1 to 10, where 1 is the least likely of having glaucoma. And this disc has a very large rim, and so this disc is least likely to have glaucoma. And 10 is the other extreme of the score, where the extension of the loss of the rim is more than 270. So the midway is 5, where the rim diameter is 10% or 0.1 to the disc, and this is a midway between no risk and highest risk. And he also considers the size of the disc. And as Dr. Ali said, when the same rim to disc ratio is in a smaller disc, so this is at a higher risk of 1 stage on the scale of the disc damage likelihood scale. And if it is larger, then the likelihood of having glaucoma is less. So Smith put these 10 scales of the disc damage likelihood scale and considers that from 1 to 3 are normal, and from 5 to 10 are abnormal, and 4 is an equivocal. And more, you'll find that 5, 6, and 7, these are indicative of glaucoma damage, but most probably there is no glaucoma disability. The patient does not feel of any disability. But after 8, from 8 to 10, usually there is glaucoma disability. And this is very easy to remember. So if the rim is 10% of the diameter of the disc, then most probably there will be glaucoma damage. If the loss of the rim is more than 180 degrees, then most probably there will be glaucoma disability. And 4 is equivocal between the normal and affected people. So we look at this, we look at the rim by the parameters that Dr. Ali has mentioned, and we look at the diameter, and then we try to make the proportion between the rim diameter and the disc diameter. So we look at the rim, and then the cup, as Dr. Ali said, and then this is 0.4. So this is disc damage likelihood scale 1, and this is the circumference of the disc, the circumference of the cup, and this is the thinnest part of the rim. It's 0.3 to 0.4 of that of the disc. So this is a disc damage likelihood scale 2, and this is on the temporal side. We can also locate where is the thinnest part of the rim. So the disc, the rim, the thinnest part of the rim, this is between 0.2 and 0.3. So the disc damage likelihood scale of 3, and it's temporal. You look at this. So it's 0.1 to 0.2 with a disc damage likelihood scale of 4, and it's also temporal. Look at this, and these are the instructions of Dr. Ali. We look at the bend, and this is the thinnest part of the rim, and it's 0.1, disc damage likelihood scale 5, and it's on the nasal side. This is on the temporal side, also 0.1 with risk of 5, and it's temporal. And you look at this, you find there is a loss of the rim of less than 90, of 45 to 90 degrees, and so it's disc damage likelihood scale 6 on the temporal side. So disc damage likelihood scale is superior to the cup disc ratio. It's normal between 1 and 3, and most probably this disc is unhealthy if it is more than 5. And when it is correlated with the visual field, it shows significant correlation with all global and sectoral visual field indexes, as you can see. And comparing it with the cup disc ratio and the OCT, you'll find that it had the best predictive power. So disc damage likelihood scale is not without limitations. For example, in tilted discs, you cannot define the rim. And if you have multiple areas of rim damage, then it would be difficult to describe the disc damage likelihood scale. But still, it is an ideal diagnostic test, as it is readily available in all our clinics by the means of binocular microscopy with the pupil dilated. It's accessible. It does not cost any extra costs, easily interpreted, and with a permanent baseline if there is a good photography and a good record. And it can be staged, and so we can know the baseline and the progress, and we can follow up glaucoma. Compared to the OCT, which is an investigational tool, it's not readily available in all clinics. It's with extra cost. It needs learning of the personnel. It has limitations in high myopia and debate about registration of the edges of the optic disc. And the big obstacle here is the changing technologies, the rapidly changing technologies in the OCT with the rapidly changing softwares. They are improving, and every software is giving better and better parameters and comparisons. But still, glaucoma is a chronic disease with very long duration, and we need to compare results with the same tools, with the same software. And this is still not available in the OCT. So the take-home message is that disc damage likelihood scale is a helpful, communicable tool to determine the risk, severity, and progression of glaucoma. Clinical assessment and photography of the optic discs are still cornerstones in the management of glaucoma. They are very important to assess the disc clinically before jumping into investigations. And thank you very much.
Okay, thank you very, very much, Professor Ayman, for this excellent demonstration of this rather difficult examination evaluation tool is this damage likelihood scale. And having mentioned this, I would like to ask you, sir, how do you recommend the practical utility of the DDLS? I mean, would you recommend we print, for example, this table on a sheet of paper and hang it on the wall of the office? Or how do you practically use it, sir? Because memorizing it, of course, or using it from memory is a really difficult task. So give us your tip about the practical utility of that issue, sir, please.
As a matter of fact, usually when we started using the cup disc ratio, there were prints and, for example, applications or cards, and you look at the disc and then you look at the card and compare. Actually, you don't need to know that, because simply you have to know only the two, the 5 and the 8. And the 5 where the rim is less than 10% of the disc, and the 8 where there is loss of more than 180 degrees of the rim. If you remember this, only these two, you don't need any chart or anything to memorize you.
Thank you very much, sir. We have a question from the audience. They would like you to stress the importance of why the DDLS is superior to the cup disc ratio, although we do measure the cup disc ratio in the DDLS. So please, we would like to just a reminder to the audience, why is that superior to the cup disc ratio? Just a reminder.
Because the cup disc ratio does not consider the size of the disc, and the cup disc ratio does not consider the thinnest part of the rim.
Thank you very, very much, Professor Ayman, for this excellent presentation and actual simplification of the DDLS, because sometimes it looks really difficult. So thank you very, very much, sir, for this clarification. Thank you.
You're welcome.
Now with an Arcadia.
Hello, doctor. Greetings from Arcadia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. I'm going to talk about dry eye patient, especially who is associated with itching. Arcadia offers the integrated solution from Orca-Post and Polyfresh Extra. Orca-Post is anti-itching and anti-allergic agent, which is not only has exceptional antihistamine effect, but also has a novel special mechanism as anti-itching agent by inhibiting nitric oxide secretion at nerve endings. The second arm of our solution is Polyfresh Extra, which is a new combination that gives extra hydration effect and balancing the tear film osmotic pressure, in addition to the anti-inflammatory effect of glycerol. Thank you for your time.
Okay, now we would like now to conclude our webinar tonight with the, let's say, the dessert of our webinar tonight with our dearest eminent Professor Karim Rafat, which will talk to us about the OCT in glaucoma, structure versus function, which is a really sensitive issue and important, having discussed OCT separately and optic nerve head examination separately. Let's check and see if there is a real link and the structure-function relationship with our dearest professor, our eminent Professor Karim Rafat. Please, sir, take the lead. Thank you very much.
Good evening, everybody, and thank you having you with us. My presentation today about the structure versus function in glaucoma. Actually, this has long time debate, and now we will try to see that this debate does not need to be. As Dr. Ayman mentioned, if we define today's definition of glaucoma as a progressive neurodegenerative disorder characterized by loss of retinal ganglion cells. So I put an underline under the word progressive. It is a progressive disease. So if we define it, it is a chronic progressive optic neuropathy with corresponding loss of visual function. So being progressive, we have to get an early diagnosis and prompt treatment and close monitoring of the case. So actually, before passing into the technologies and the diagnostics and the machines we have, it is an office-based disease diagnosis, depending on the history, the systemic workup, intraocular pressure, gonioscopy, central corneal thickness, and optic disc. All these parameters should be done first in an office-based clinics. Then comes the investigative tool, and as Dr. Ayman mentioned, it has both the structure. We have the optic nerve head examination, as beautifully illustrated by Dr. Khalifa and Dr. Ayman, and then comes all the technologies from the Heidelberg OCT to the confocal scanning laser ophthalmoscope to the scanning laser polarimetry, and recently, as we mentioned, the OCT angiography. And then comes a functional component. A functional component, the standard automated perimetry, meaning white on white, or the frequency doubling technology, or the short-wave lens automated perimetry, the blue on yellow automated perimetry. But always remember that 1/3 the cases of glaucoma has no intraocular pressure rise, and about 35% are undiagnosed, and the evidence-based medicine tells us that these patients have an eye examination in the last year, so things can be missed in these events. So for early diagnosis, we have two questions actually. First, the early diagnosis. How to detect the changes that occur first, either functional or structural measures for early diagnosis. And then, in diagnosed cases, how to monitor these cases, better functional or structural measures. So in this talk, I will try to solve these two questions and see which one to use first, functional or structural, or actually both. The first part of the question is the early glaucoma diagnosis. How can we diagnose glaucoma early, very early? We depend on two parameters, either the presence of structural and or the functional changes, or detection of progression in either structural or functional measures. And still IOP is still there, but not as a definition part. It is a risk factor for this diagnosis, early diagnosis. But also, besides this early diagnosis, we have to avoid the overdiagnosis. Sometimes the suspicious mind gives us an overdiagnosis. And I quoted this from George Space in his textbook. The decision to initiate an anti-glaucoma therapy is a very serious one that have far-reaching consequences. Of course, we know that it has side effects, significant costs, and altering the quality of life. So we don't have to be biased either overdiagnosis or underdiagnosis. And always remember, in spite of all these technologies we have, the OCT, the OCT angiography, the very, very sophisticated technologies, it is our duties as physicians to diagnose and manage our patients. These technologies and these machines and these data can only confirm or rule out the diagnosis, and always its diagnosis, our patient condition, it is our duty. These machines can alter only the probability. So, how early can diagnose glaucoma? If we look at the optic disc appearance and visual field effects, both are very useful, but let us look at it very cautiously. For the visual field, as we heard, it is subjective and depends on the patient cooperation, and it has some learning curve. For the optic disc, as we see, it needs very meticulous examination and needs skill and experience for this interpretation. Also, the variable appearance, as we heard, of the normal optic disc, actually this word normal optic disc is sometimes an elusive term. And the change of cup, as we heard, also represents a loss of thousands of axons. If we look at all these discs, these are variable appearance, but all sometimes considered normal, depending on the disc border sometimes not very well defined, the disc size and the peripapillary atrophy, as we heard. So this is very important, as Dr. Ali mentioned, but it needs a lot of experience and skills. If we see here with the technology we have, the OCT, glaucoma actually affects the 3 areas in the posterior segment of the eye. The optic nerve head with the coupling and the data all collected about the rim area and rim volume, the peripapillary nerve fiber layers, and the macular ganglion cell complex. If we take this one by one, the peripapillary nerve fiber layers is done by doing a circle scan of fixed diameter, and let me emphasize it's a fixed diameter 3.4 millimeter in all the machines. It's very well centered on the optic nerve, around the optic nerve head, and then this circle is spread into a line, and the machine identifies logarithmically the beginning and the end of the nerve fiber layer, and identifies this with these 2 red lines. And what's in between these 2 red lines is measured and expressed in different ways, either in numbers or in what we call the T-SNIT curve. T-SNIT stands for temporal, superior, nasal, inferior, and coming back to the temporal. And we always see this bi-hump configuration because the superior and the inferior poles have the thickest gathering of the nerve fiber layers, so causing this bi-hump configuration. The patient's scores are put in this dark black line, and then compared to the normative database is stored in the machine computer. For the green area within the acceptable range, yellow is borderline, and red is not acceptable or below the acceptable range. The whole picture here is give us the clue, OD and OS comparison. To facilitate things, they put it either in the clock hours, and each clock hour giving a score, and compared to the normative database, given the color codes, red or yellow or green, and then we put it in a table comparing the different numbers of superior, inferior, maximum, and very importantly is the asymmetry, how to compare OD-OS ratio and give us this comparison, and put it in a graph, the OD with a straight line and the OS with a dashed line. And we see here very obviously that the superior and inferior poles of the left eye are markedly reduced, giving these red marks here on the vertical meridian. But as with the OCT angiography, there are many contaminating factors and many precautions before taking this number into considerations. First of all, is a proper fixation is very important. Even sometimes the involuntary saccadic movements replaces this supposedly square circuit, continuous circuit, into variable dots of different dimensions and different sizes. Also, the proper centration is very important, because as decentration of this circuit getting close to the disc, it gets closer to the thicker part of the nerve fiber layers and give alteration on the nerve fiber layer numbers. And most importantly is the segmentation. This is an ideal segment showing the nerve fiber layer beginning and end very well identified. But this is not always the case. Sometimes we find this poor segmentation due to either media opacity, myopia, or sometimes vitreous floaters, as we will see, causing this poor segmentation. And the machine gives us number. If we compare this read as an abnormal, it's not, because this is poor segmentation. And here also, the poor quality of the image, either due to media opacity or some vitreous haze, produces no proper identification of nerve fiber layers. And here you find that patient's line is flying on the floor and giving all red. Actually, this is very poor segmentation, not a true values. Again, here is a machine. Actually, here is measuring the sclera. He missed all the retinal and nerve fiber layers and measuring the beginning and the end of the sclera and give us very fallacious numbers. Also, the peripapillary vitreous opacities. Sometimes we see during work this vitreous floater coming and then crossing our circle here, so causing this black shadow and causing this sector to appear abnormally thin, just because of this vitreous floater. In these cases, you ask the patient to move the eye or blink twice, then this floater moves away, and I should get the circle completely free of these floaters. Another contaminating factor is vitreoretinal traction. Sometimes we find this vitreous adherent to the nerve fiber layer and pulling traction on these focal points, giving abnormally false high readings. And when this becomes loosened and the vitreous is not attached to the retina anymore, we find apparent thinning, which we identify as progression, which is not the case. So we have to look first for this B scan and look at this vitreous traction on the retinal nerve fiber layer. Another issue which should be considered is the association between diabetes and glaucoma. Diabetic patients sometimes have diabetic macular edema, and the edema causes appearing very well with subretinal fluid and cystoid edema in the macula. But remember, this edema does not only involve the macula, but also involves the peripapillary nerve fiber layers. So give us a false sense of security that these nerve fiber layers are on the high range, but they are not. And remember, I always ask my patients, if they are receiving anti-VEGF, this patient receives 3 anti-VEGF injections, and then the edema subsides, and also the nerve fiber layer edema subsides. So give us a false reduction of the nerve fiber layer due to the anti-VEGF and not due to glaucoma progression. And always remember this very interesting paper that cautious interpretation is recommended for the evaluation of glaucoma in nerve fiber layer thickness in diabetic patients, especially with diabetic macular edema, and always remember this relation. Another contaminating factor which should be put into consideration is the optic nerve size. Because, as I mentioned, the circle is stationary. So if a patient has a large disc, this circle gets closer to the edge disc. And as I mentioned in the anatomy, the closer to the edge disc gives us a thicker nerve fiber layer. So it gives us a false sense of security. While a patient with a small disc, the circle is the same size circle far away. So it gets in the thinner area and gives us a false positive diagnosis of glaucoma. So we always take, the machine gives us the disc size. If it's larger than 3 square millimeters, we be very careful about the false negatives. While it's small, less than 2 square millimeters, be very careful about the false positive results. And again, as we saw, these numbers are compared to the normative database, but we should be remembering that these normal databases differs from ethnic groups. Asians differs from Caucasians, differs from Africans. So we have to put this ethnic group into consideration. Always the age. The machine have only between the 18 and 80 years. Under 18 years, we don't have a normal database. And it always varies with the axial length and refraction. And as I said, with the disc size. And sometimes the variations with the anomalies, the peripapillary atrophy gives us a variation which is marked as red, which is not as red as a disease, but red as a misinterpretation of the machine. So when we compare our data with the diseased eye to a normative database, this is actually a very normal control, and this comparison actually is not a fair comparison. Again, when we see red sectors here in the OCT, look first at this area. Don't take any red as abnormal. Look first is the misinterpretation causing this red appearance. Don't take any red fake granted, take it for granted as an abnormal. And remember what we call the green disease. The green disease is the patient have higher than normal or near the highest range of this area. We can miss progression because this patient is progressing and getting nerve fiber layer loss, but still in the green zone because we started very high in the green zone. This is a green disease. And remember, these data are just statistical significance data. The red appears in only about 1% of the normal population, and the yellow occurs about 5% even of the normal population. So all this should be put into consideration before taking these numbers into account. What about the optic nerve head parameters? Of course, the clinical, and as we said from Dr. Ali and Dr. Ayman about the optic nerve head evaluation and the 5 rules of precious 5 rules of Dr. Ali, we have to look about the optic disc evaluation in the OCT. We find here many parameters of the optic nerve head, but we usually concentrate on the more, as the evidence-based medicine tell us about the importance, the rim area, the vertical cup disc ratio, and the vertical rim thickness. And we compare again the OD and OS, we see the difference in these parameters and give us the symmetry between these two eyes. In new, as Dr. Ayman mentioned about the rim and the importance of the rim more than the cup. The technology also applied here when we have the software upgrade about the post-membrane opening minimum rim widths, what we call BMO for post-membrane opening, MRW minimum rim widths. Here the machine measures the Bruch's membrane opening and put it as a red dot here, and then identifies the internal limiting membrane here, or the inner layers of the retina, and measures the different dimensions of this rim area, perpendicular lines, and from this area we can plot a rule of the rim width, and we see which part is the thinnest part and tortoise with the same significance as the nerve fiber layer thickness. Here's how to machine identify the Bruch's membrane opening of the Bruch's membrane, and then perpendicular line, and calculate this minimum rim width. It is geometrically more accurate in evaluating the neuroretinal rim tissue and stronger association with the visual field parameter, as Dr. Ayman mentioned with his great scale. The last thing with the OCT is the ganglion cell complex. The ganglion cells, actually we call it a complex because it's not a single layer. Actually, it's 3 layers. Ganglion cell layer, their axons, which is the nerve fiber layer, and their dendrites, which is the inner plexiform layer. All 3 collectively called the ganglion cell complex. And the machine identified it by segmentation from the internal limiting membrane to the end of the internal plexiform layer, and give us different presentations. The significance map down here, again with the red flag, meaning there's a great thinning below acceptable limits, is the inferior part of the macula. Progression is very important also. If we document that the red zones are progressively increasing, this means that the disease is not controlled, and we are losing the ganglion cells, even if there is no progression in the nerve fiber layer thickness or the visual field defects. It's very early diagnosed. Even with the normal field and the normal nerve fiber layer thickness, we found the yellow patch here of ganglion cell loss. So we can detect it at an earlier stage. It is the primary site or primary target of damage in glaucoma, this macular ganglion cell loss. So we have many technologies, both structural and functional, how to correlate and how to properly use both together. If we look at the disease progression, from the left is the early disease, and to the right is the advanced disease. We find here that the visual field at the early stages are more or less stable. And as I said in the first slide, this glaucoma is a progressive disease. We need to know progression. So we cannot detect progression in the early stages with the visual field. While the structural changes here, the disc and nerve fiber layers, there is progression here, and we can detect this progression at an earlier stage. And very interesting studies were done about the glaucoma suspect patients, and they followed up longitudinally. They found it stable in about 63% and progressing in 37%. But this progression was detected far more with the spectral domain OCT than the visual field. And for the glaucoma already diagnosed cases, they were followed stable and controlled with 67%, while progressing is 33%. And again, this progression was detected far more in the spectral domain OCT with the structural mean more than the functional with the visual field parameters. So why is that? If you compare structure versus function, we found that the visual field is subjective, depending mainly on the patient responses. It has a learning curve. And studies have shown us that the between visit reproducibility for the mean deviation, for example, is not little. It's about 13 to 28%, while OCT is objective, fast, with high accuracy. The between visit reproducibility with the nerve fiber layers is only 2.47%, with the ganglion cells is only 2.2%. It's much higher reproducibility than the visual field defects. And the review in the literature shows that the structural loss precedes the functional loss by 6 years in 60% of eyes. And as much as 20 to 40% of ganglion cell loss occur before the standard automated perimetric visual field is lost. So it's a long time. We need to diagnose it much earlier than this. You don't have to wait to lose about half the ganglion cells to detect the visual field changes. And again, as Dr. Ali mentioned, changes in the cup represents a loss of thousands of axons. And the review also shows that up to 30% of eyes have abnormal thickness values 4 years prior to detectable visual field loss. Is the clinical practice. And if this period is increased to 8 years, we've had about 19% of the eyes have abnormal thickness before any detectable visual field loss. Let me show you one of the clinical situations we sometimes meet. A patient with suspected glaucoma suspect. If we follow the field, we find it over time, it is stable, no appearing changes at all. But when we follow the OCT, we find some progression. The yellow sectors here becomes red, and more red, and even the green becomes yellow. So there is loss of the ganglion cell. So this is what we call the perimeter glaucoma. The nerve fibers are affected and progressing, but the field is not progressing. And here there is a debate. We start treatment depending on this just papers and numbers, or we follow up these patients. And let me put two scenarios. If the patient have an intraocular pressure within normal 14, or a patient have 26 millimeters mercury, and another scenario, if this is a young patient in the 30s or an old patient in the 70s, will it make a difference? Yes, I think. If the patient have a high IOP at a young age with longer life expectancy, we should not leave this patient to lose more and more of these nerve fibers over time, even when the field is still not affected. This is for the first question about the early diagnosis. What about the glaucoma progression? Progression actually is a challenge. Why? Because it's very insidious, variable, unpredictable, and varies with disease severity. And variable measurements we have, and we lack of acceptable reference standard. What's changed is a real change. So to put it from the start, to get to glaucoma progression, there's no gold standard, and we have to do both functional, structural, compared together. For example, in this case, we are lucky to have something like that. If we follow the patient closely, we find this inferior sector is green, becoming red, and then later the superior sector becoming yellow, follow-up becomes red. So there is a definite progression in a particular pattern in the vertical and sparing the horizontal meridian. So if this is a glaucoma suspect, no, it is a confirmed diagnosis now. And this, if the diagnosed glaucoma patient, this is an uncontrolled disease, and we should do a therapy advancement or lower target pressure. Again, if we compare the structural functional progression, we find here for the diagnosed cases, it's a early disease on the right side of the graph, or the advanced disease on the left side of the graph. We find here in this sector that in the early disease, the quick change we can detect the progression is in the average nerve fiber layer structural component. But here the mean deviation of the field of vision is more or less stable, and we cannot easily detect the progression. On the opposite side here, in the advanced disease, we find here the nerve fiber layers is almost a plateau, and here the steepness of this mean deviation is a more detectable, and we can detect the progression here more in the advanced with the functional mean deviation of the visual field. But with the OCT, what change is a real change? Will we find 1 micron difference? Is it a real change? Actually, we don't have these minor changes because there's a machine intervisit variability. The literature gives us a clue for this. The average thickness of the nerve fiber layers have a variability of about 2.7 microns. The quadrant have about 8 microns intervisit variability. The clock hour have 12 microns. So as we go more and more narrowing, we get a higher number. So when we put 2 standard deviations, we consider about 5 to 6 microns of change in the average nerve fiber layer thickness is a real change. 1 or 2 microns, sometimes we consider it with the machine variability. But actually this average can miss focal changes. If a 1 clock hour is affected, it can be diluted with the all fixed numbers or even some higher numbers in other clock hours. So sometimes we look what we call the event-based analysis. We look 1 clock hour by 1 clock hour, but here we wait for a larger number of changes to occur in these clock hours. What about the progression of the visual field? Again, there is some what we call margin of enter-test to retest variability. The ideal is this test to retest is this straight line here, but actually this is not the case. For the early disease of the case, there is a margin, a gray zone around it, up or down, which is considered still a variability. And as the disease progresses with the markedly impaired function, we find this area becomes greater. And for the machines, we put the glaucoma progression analysis, consider what's within this gray zone, the narrow zone in the early disease, and the broad zone in the advanced disease are not progressing. But if it's outside this border zone, this gray zone, it's a progressing disease. And we compare 3 visual fields and give us a clue which are points are progressing, which points are moderately, and which points are stationary. This is a glaucoma progression analysis. What about the macula? We are always talking about the peripheral nerve fiber layers only, but remember that although the macula constitutes about 1/20 of the retinal surface area, it contains about 1/3 of the retinal ganglion cells. So the classic teaching that the macula is spared in advanced cases actually is not the true with this technology we have. Early glaucoma can still damage the macula and affect the macula, although not detectable, because if we depend only on the central 24-2, this can miss the central field effects because there's only 4 points here in the central 8 degrees. So better to zoom in and to get the 10-2 strategy to highlight these central field defects. And remember that the moderate cases of glaucoma, half the eyes, 50% of the eyes have glaucoma damage within the central 30 degrees of fixation. So focusing on the macula with the 10-2 strategy of the field on the ganglion cell complex is very important, and even here in the advanced cases. It's because these macular fibers are spared to late stages, so ganglion cell thinning can be monitored and observed even when the retinal nerve fiber layer holds, as we said before, in the advanced cases, and the retinal nerve fiber layers stops of value, still the ganglion cells of the macula can have some value to detect this progression. A very important index now, why to do separate studies about the structure and function, why not to combine together? Very important studies have been made and very complicated mathematical equations, what's called the retinal ganglion cell estimates. Here was very sophisticated mathematical equations combining the standard field, visual field, automated perimetry, and the spectral domain OCT measurements. He gave an estimate of the ganglion cell count, how many cells counted here. And when compared to the animal models with an experimentally induced glaucoma, they are very good matching. So with these retinal and ganglion cell estimates, there is a lower in eyes developing glaucoma and than in eyes which are not. And 28% confirmed against these studies. Ganglion cell loss associated with early visual field defect. This is a big number. We don't have to wait till a quarter of the ganglion cells are lost to detect the visual field effects. And when compared to the standard spectral domain OCT alone or the cup disc ratio alone, this retinal ganglion cell estimates is more importantly and more outperforming in these facilities. Another studies were done with these retinal ganglion cell counts, and we see the correlation between the loss of the ganglion cells with the functional progression detected by mean deviation decibel loss per year. At the early, with the right side of the graph, there is early loss from 140 times 10,000 cells, losing ganglion cells, and the field still not changing. And here with the moderate loss, the field starts to rise again, and we are losing here decibels in the mean deviation. So we can miss this loss of the ganglion cells if we follow only with the visual field. And again, it discloses another thing. Loss of the ganglion cell estimates is not always associated with thinning. We find here we are losing ganglion cells, and the structural ganglion cells in microns, nerve fiber, ganglion cell thickness in microns is stationary till we reach a moderate loss. Then here the ganglion cell thickness starts to be affected. So there is a blind zone here which cannot be detected by only measuring the function or the structure of these ganglion cells. What does evidence-based medicine tell us? The classic teaching, and we used to teach our students maybe 20 years ago, that the agreement of structural and functional losses are solid diagnosis for glaucoma. But actually now we see this is the exception rather than the rule. For the ocular hypertension study rule, only 7% will show agreement between the optic disc appearance and the visual progression. And 35% of cases, the OTCD demonstrates damage 4 years before the standard automated perimetry showed changes. And the early manifest glaucoma treatment showed that the baseline visual field effects are very important, because these patients with baseline starting defects here have a higher risk, about 4 times risk of visual field progression than the patient with the baseline, no visual field effects. And here both structural and functional are the same analysis. Right. We are lucky if we see a case like that, where we find that there's an inferior thinning associated with an upper artery scotoma. So this is an ideal situation, but this is not always the case. Sometimes we find that the nerve fiber layers are very good in the green zone, and we find some moderately advanced functional damage. And the reverse, we sometimes found markedly affected nerve fiber layers with minimal or moderate damage on the functional compartment. Why is this discrepancy? If we review the literature, we find these discrepancies have many explanations. Why is the discrepancies? Sometimes 1 clock hour is too wide to demonstrate localized loss. If we find localized loss here and the average is diluted within the clock hours or within the quadrant, this thinning is missed. Retinal nerve fiber layer defects is not always a result in retinal nerve fiber layer reduction. Again, reduction of the nerve fiber layers does not exceed the normal variation, as I mentioned before, what we call the green disease, because we start on the higher range of the normal. So if we lose, we are still in the green zone. Sometimes the order of glaucoma damage may vary from patient to patient. Again, we should always remember the physiological age decay of the nerve fiber layer, sometimes contaminating factor. We are losing about 2 microns per decade or 0.2% per year of the nerve fiber as a normal age decay. And what we are doing in glaucoma management is not to stop this, but we need to revert the accelerated decay to this normal age-related decay. And the important is that this age-related decay is least in the inferior quadrant. That's why the inferior quadrant is very important to discriminate between normal and glaucoma patients. Sometimes the diffuse loss of the nerve fiber layers is so large to mask the localized defects. And again, the OCTs, as I mentioned before, when we come to advanced glaucoma like this, and here we call it the floor effect. Here, what's actually measured is not nerve fiber layers, just vessels, glial tissue, and molar fibers left here. So, and this number has been put when we find the average is within or below 55 microns. Here, the OCT has very limited rule because there's no more nerve fibers to measure or to follow. So, to conclude, we find from this that the spectral domain OCT performs better in the pre-perimetric and the early stages of the disease, but have little role in the advanced cases. While, as I said, the floor effect with the average nerve fiber is below 55, while visual field is more relevant in later stages, established moderate to advanced stages. And better now is to ensure the high diagnostic performance and sensitivity to progressive loss, and management protocols need to include both structural and functional measures. But remember, we rely on both, but we do with that. With ocular hypertension and suspect, we rely more on the spectral domain. With the early perimetric, again, with the spectral domain OCT, mild to moderate, we can use both, while in advanced, we rely more on the visual field for progression and follow-up of these patients. And the take-home message is that there is a large overlap between the normal and the mild or early glaucomatous findings. Makes diagnostic determination upon a single field is difficult. And again, detection of change over time may be the only reliable means to confirm the presence of the pre-perimetric glaucoma. And combination of data now with the software of the machine put both the field functional and the OCT, the structural component together, and this add more to our diagnostic capabilities. And if you look at this wise man for saying the proper glaucoma diagnosis, we should follow these rules. Use all the available data. Know what we are looking for. Take into account the quality of the data before taking into consideration. In case of change or any new abnormality, always repeat the test to confirm its reliability. And always consider other risk factors like the family history, central corneal thickness, optic nerve hemorrhage, and the appearance of the disc or rim areas, as Dr. Ali mentioned. All this put together, and always for the OCT, remember that OCT is a powerful tool, but it is up to the clinician to use it correctly. So we don't be misled by false numbers or false segmentation, give us a false clue. And thank you very much for your kind attention. And I hope this adds to you about the diagnosis and follow-up of glaucoma. Thank you.
Okay. Thank you very,
Shukran,
very
Dr.
much,
Karim.
Mr. Karim Rafat, for this excellent presentation about a debate that should not be there, as you mentioned, sir. There's a question from the floor, sir, which asks about the green, about the normal in the green. If the Tesnit curve is all in the green, but the isn't rule is not respected, let's assume, and you have a case in which the isn't rule is not respected, yet all of the curve is in the green. Would this be okay, or would this arouse suspicion of glaucoma?
Alone, yes, suspicion only, but not confirming diagnosis, just not following the isn't rule of glaucoma is not enough to confirm this area. We have to collect all the data, the pressure, the diurnal variations, the central corneal thickness, all together, and to collect this and put suspicious, as I said, all these technologies just raise or lower the suspicion, but not confirming or denying the diagnosis.
So, I mean, the presence in the green zone alone in itself does not say anything. It has to be combined with the clinical findings and things like that.
Exactly. Sometimes find glaucoma patients with the green, all green.
Okay. Do you have any clues, sir, about the OCT in glaucomatous myopic patients, sir, or it's again the same debate and difficult to answer?
With a very high myopia, say minus 18 or 20, here many factors make the segmentation and the tilted disc, the peripapillary atrophy, all these combined together to make the OCT very misleading, actually, because the segmentation of the machine and the low grade of the quality of the image makes the identification of nerve fiber layers is very low, and sometimes we find nerve fiber layer loss, but this is from myopia or from glaucoma is sometimes difficult to diagnose, depending on the OCT alone.
Thank you. There's another question. Is there any, are there any specific findings in the en face OCT or the cross-sectional OCT to suspect glaucomatous changes? I mean, from the image of the OCT rather than the Tesnit?
Yes, for the time's sake, I didn't mention this en face. En face OCT is very useful in diagnosis many macular and optic nerve diseases, including glaucoma. With the en face, as we saw before, with a green filter or the slit lamp, you can see the striations on nerve fiber layers. This is very, very obviously with en face OCT. We can detect loss of sectors or even lines of the nerve fiber layers with this en face OCT. Yes.
Okay, now we have, let's say we'll conclude with this question from the audience because we're running rather late. What are the cutoff values for the normal peripapillary RNFL thickness regardless of the color, or do you rely on the color? I mean, the color is related to the database of the machine and this is technically derived. So are there any clues for the absolute numbers to rely upon?
Yes, there is some with time and with experience. We put some average number for our community here, the Egyptian population. And we have made a study first back in the 90s. We made a study about this normative database in the Egyptian population. We find for the average nerve fiber layers from 110 to 120 is acceptable as a high range. And the lowest range we find about 90 to 100 is the lowest range for this normal average in our Egyptian population.
So, thank you very, very much, Professor Karim Rafat, for this excellent presentation and for having the time and nerves to answer our attendees' questions. We would like to remind all our attendees of our upcoming annual Congress. It will be the 20th. The 20th Annual Congress of the Egyptian Society for the Glaucomas. Please mark your calendars on October 29 and 30, and please note that the submission and registration, abstract submission is now open, has been extended to the 25th of September. Please submit your abstracts, please mark your calendar, and your valued attendance is always valued and welcomed. And having said so, I would most honorably like to conclude our webinar, and to thank our honorable guest speakers, Dr. Gabor Hollo, our very eminent professor speakers from Egypt, Professor Ali Khalifa, Professor Ayman Al-Shati, and Professor Karim Rafat. Thank you very much for all our attendees for staying.
Thank you, Nader, for moderating this session. Thank you very much.
Thank you very much, sir. It was a real honor, and we would hope to see you soon in the near future. Thank you very much, and good night.